going to be discussing the helper mnemonic from the American Academy of Family Practice for the management of shoulder dystocia. H. H stands for ask for help. You're going to want to have assistance from your obstetrician and anesthesiologist. You're going to want to have additional nurses in the room to help with things such as the McRoberts maneuver, as well as pediatrics and NICU nurses to help with the baby. E. E stands for evaluate for episiotomy. Enlarging the vaginal opening by performing episiotomy will give you more room to place your hands inside the vagina to perform some of the maneuvers which will follow. However, making a soft tissue cut will not relieve the bone-on-bone dystocia. L. L stands for lift the legs. This is the McRoberts maneuver. You want to flex the mother's thighs as high as you can onto her abdomen. This may remove the shoulder dystocia in 3 ways. Firstly, this motion rotates the symphysis pubis up and out a bit, thereby increasing the pelvic diameter. Secondly, flattens the sacral promontory. Thirdly, these motions may actually help to shake or move the baby's shoulder off the symphysis. P. P stands for apply suprapubic pressure. You want to have a CPR style hand position and apply pressure to the posterior aspect of the baby's anterior shoulder. This should be with a rocking motion. This maneuver should be attempted for about 30 seconds, as with the other maneuvers. To demonstrate, what you're attempting to do is to actually move the baby's shoulder anteriorly on the thorax, thereby decreasing the bisacromial diameter, or just relieving the dystocia by shaking the shoulder off the symphysis. What you do not want to do is to do fundal pressure. Fundal pressure will only act, this is your dystocia, fundal pressure will only act to impact that further. E. E stands for the enter maneuvers. First one we'll discuss is the Rubin maneuver. In the Rubin maneuver, you want to place 2 fingers from one hand behind the baby's anterior shoulder and attempt to rotate it forward, thereby rotating the baby through the pelvis. To demonstrate, what you're attempting to do is to rotate the baby's shoulder anteriorly like this. That's the Rubin maneuver. Next maneuver is a wood screw. So you still have your 2 fingers posterior or behind the anterior shoulder. You then attempt to take 2 fingers from the other hand, place them anterior to the posterior shoulder or in front of the posterior shoulder, and simultaneously rotate the baby through the pelvis. That is your wood screw. To demonstrate, you're going to have 2 fingers behind the anterior shoulder and 2 fingers in front of the posterior shoulder like this, and you're attempting to rotate the baby. If that doesn't work, then you can do the reverse woods. In this case, you put 2 fingers anterior to the anterior shoulder, 2 fingers posterior to the posterior shoulder, and again attempt to rotate the baby through, but in the opposite direction, as such. So for that maneuver, you'll have 2 fingers anterior to the anterior shoulder, 2 fingers posterior to the posterior shoulder, as such, and then again you're attempting to rotate the baby through. Okay. Now the R stands for 3 things. First one is remove the arm. With that, you place your hand in underneath the baby. Run your fingers along the baby's humerus. Once your fingers get down to the antecubital fossa, and you press on it, the arm will flex forward, the elbow. You can then grasp the forearm and either pull straight out or try to sweep it across the baby's chest and rotate the baby out. So to demonstrate, you run your fingers along the baby's arm. Once you reach the antecubital fossa, the forearm should flex up. You then grasp the forearm and either pull straight out or sweep it across the baby's chest, rotating the baby out. Second part of the R is roll the patient. Roll the patient onto all fours. You then do the exact same type of maneuvers as you would do if the woman was on her back. By rolling her onto all fours, the pelvis will fall off the spine and open it up about 1 centimeter, the pelvic diameter about 1 centimeter. Plus, just again, the motion may actually act to dislodge the shoulder from the symphysis. So you move the woman into position, then you just do the gentle traction downward. And hopefully the baby will just nicely deliver. If it doesn't, then you can do those same maneuvers again. Reuben, wood screw, reverse wood screw. Now let's say we've done all of those, still no delivery. We then get into rescue maneuvers. There are a number of them discussed: fracture of the clavicle, posterior sling. I'm going to describe 2. One is symphysiotomy. Now symphysiotomy, you place your fingers into the vagina, you take the urethra, move it to one side. Or actually, prior to that, you'll have actually infiltrated some local anesthetic in above the symphysis. That. Then place your fingers into the vagina, move the urethra to one side. If you then take a scalpel blade and begin to cut down through the ligaments, once you get 1/3 to half the way through, the ligaments will just pop open, lots of room, now the baby will deliver. Most women will recover from this quite nicely. You just use a pelvic belt for about 6 weeks to hold it together. I've never had to do this procedure myself, but I have had, over the course of my career, 2 spontaneous symphyseal separations, and both women recovered with no complications. Final maneuver I'm going to discuss, another rescue maneuver, is the Zavanelli maneuver, made famous in an ER episode. What you do is you basically reverse the cardinal movements of labor and then do a cesarean. So before you can even think about doing the Zavanelli, you have to make sure you've not cut the cord. So if your cord is still intact and you've got ready access to cesarean section, and then take the baby's head, flex, rotate to OA, push up, cesarean section. Again, flex, rotate to OA, push up. That's your Savinelli maneuver.